Okay, I guess we can go ahead and get started. My name is Michelle Reed, and today we'll be going through some risk adjustment topics. We'll look at some coding edits. We'll look at some sample coding and scenarios, and then we'll run through timelines and deadlines for submission of risk adjustments. So the purpose of the HCC coding training is we've looked at data that we've received in the system. We run algorithms and reporting to find out how we could best provide training to our medical groups and physicians in order to help with maximizing risk and how we capture encounter data. And if there's any other items related to encounter data submission or coding and documentation that we can share with you, we'd like to pass the information on. So I'd first like to begin with talking about the 2019 dates of service and the extension of the CMS sweep. So as most of you are aware, CMS has extended submission of your diagnoses for 2019 service dates. And what that means is that generally all of our 2019 service dates would have gone in February as the final, but due to the pandemic and to COVID, CMS has extended that deadline through August 2nd, 2021. So we're asking all the groups and physicians, we are distributing reports, gap reports of what's missing for 2019. So if you believe that the practice may have documentation or progress notes that we have not received for service dates 2019, please submit the reports. Generally, we'd like to see them around, the end of July, well, maybe the middle of July, because the sweep is August the 2nd. So as quickly as we can get your data into the system, we can reconcile it to make sure that it's been accepted. So just be mindful that there has been an extension for 2019. So any supplemental data, we are welcoming that information.
Okay. I'll turn it up.
Okay, so let's get started here. Let me move this down. Okay, and just a couple, we may have new participants. So just a couple basic rules that we want to just discuss here: risk adjustment and higher conditioning category coding. So the model assigns risk factors to scores to individuals with serious or chronic illness based on a combination of the individual's health conditions and demographic details. And so in previous trainings and presentations, we showed demonstrations on how the model defines a patient's risk score. And that's because we're looking at demographic information, we're looking at patient health status in order to determine if we've captured everything, which defines the severity level codes, the risk score, and determines how we pay for services. All of your documentation must support the presence of the condition and indicate the provider's assessment and plan to manage the condition. So this must occur once each calendar year in order for CMS to recognize and continue reimbursing for the service. So we ask that all of the chronic conditions are assessed and documented at least once a year in the progress note charts or encounter data. So the documentation of each condition that the patient has that influences the ability to treat the patients must include pertinent conditions, the chronic conditions, the active status, history of if it's past conditions, and conditions that require two codes built together. So later on in the presentation, we'll look at those interactive codes and how we build two codes together in order to increase our risk score. So we've covered, basic documentation and coding. We know that it must be monitored and managed, evaluated, assessed, and addressed. So if there's oncology visits in your primary care, we're documenting follow-up information from various specialists. Treatment, we consider the care of the patient. So diabetes status with kidney, the doctor should indicate that he's prescribing other medications or NSAID in this particular instance. So well-documented charts so that we ensure that we have conditions and follow-up from specialists, that those are documented in our primary care charts. So we'll look at some samples on how we code and monitor based on different types of charts that we've received. So pertinent conditions, document and code any patient conditions that are present but stable, managed on therapy, if they require observation, if they require a referral to another provider for management, which influence the patient's, the decision-making in the patient's care. So all of these things that we're seeing here, the unspecified codes where we're not getting the specificity to let us know that the documentation of that particular condition is either stable. We want to make sure we have that information noted in the chart, and also observations. So these are the conditions and documentation samples that we should see. Avoiding the documenting of history of when the condition currently exists. So in the ICD-10 language, history of means that there's no longer, that the patient no longer has the condition, in which case it cannot be coded as an active disease. So if you're documenting or listing history of, we'll show some of the coding guidelines and where we should avoid using history of in the patient's assessment. Chronic diseases. So we want to document chronic conditions annually, even when they're stable. So document that the condition is chronic. We want to document the severity or the stage of the condition. So if we have kidney disease, we'll show samples of how to document diabetes and some of the CKD disease. If there's major depression, documenting. We want all of the severity, stages, and conditions documented when submitting the encounter. We also want to document the associated conditions or complications related to underlying conditions. So diabetes is a big one. We know that there's a lot of manifestations and conditions associated with diabetes. So we'll show some coding charts and how to document your diabetes and your underlying conditions in order to ensure that you're capturing all of the interactions that we should pick up on encounters and risk. Active status. So conditions that are present and unresolved are likely to be resolved through documentation, should be documented at least annually. So CMS considers a condition resolved if you have not evaluated the code and documented once a year. So there are certain forever codes, and those are codes and conditions that do not go away, and patients are expected to have forever codes in their charts. So we talked in other trainings about amputations, there's transplant status codes, and alcoholism in remission CHF compensation codes. So these forever codes, these are usually the diagnoses codes that we tend to forget to document in the progress note. So during your annual wellness exams, and when you're calling in patients for your yearly assessment, we want to look at all the forever codes to make sure that we've redocumented all of the conditions that would stay permanent within a patient's chart. So as you know, if it didn't come in through encounter, or if it wasn't documented and charted, then it doesn't exist. And CMS will reset that member's risk score, because it looks to CMS as though that information or that disease has been resolved. And so as you know, conditions such as amputations never resolve themselves. So we want to ensure that we're documenting them. So forever codes may also include ostomy, cirrhosis, diabetes, hepatitis, paraplegia. So we want to be specific. And again, with the forever examples we showed up above, we want to make sure that we're also documenting the additional codes. History of or past conditions. So if there's a history of cancer, if it's not active treatment and it does not have the disease, have an active disease, cancer on long-term therapy is an active cancer when the therapy is not prophylactic. So when we're reviewing our cancer diagnoses, we want to follow the coding guidelines as it relates to cancers. And I'll show a demonstration of some of the CMS coding guidelines so that you have a reference to read on the cancer section regarding how to document and include cancers if you're showing a history of or past history of cancers. History of stroke or CVA, document deficits and history of incident too. So hemiplegia or secondary to CVA codes, those should all come over and be included as a part of your encounter data. Conditions that require two codes be built together. So this is where we'll show you some diabetes manifestation and examples, so neuropathy, peripheral, those types of conditions, making sure that we have both codes assessed in order to maximize the risk. So we'll show you the diabetic HCCs and how they categorize into the ICD-10 model in order to ensure that we're picking up the highest level. Hypertensive and renal disease, we want to document both hypertension and renal disease so that we're getting the interaction on the HCC model. So we want to ensure that we're coding and documenting all of the hypertensive and renal disease and associated conditions. So here's a reminder, back in 2019, there were 4 new HCCs which were included to the model. HCC 56 was added for drug abuse uncomplicated except for cannabis. So if you refer back to your HCC code model, you'll have an outline of all the drug abuse codes within this category that will now risk adjust. Same thing with the unspecified psychosis under HCC 58. Personality disorders were also added. And then here's a big one, HCC 138 for chronic kidney disease stage 3. So previously we were only able to risk adjust on stage 4 and 5. So stage 3 is now a condition that should risk adjust. And so what we've done through data is we run data, look at reports of those members who previously had an HCC or diagnoses of CKD stage 3, run some data, and I would also recommend running data from your internal EHR systems to identify those members. Any members that are showing stage 3 CKD, if you had it noted before in your EHR that it did not risk adjust, making those changes to your system so that you're submitting that diagnosis and that we're getting it over to CMS in order to capture this particular diagnosis code ranges and HCCs. So stage 3 is now going to risk adjust on the model. ICD-10 code structures. So CMS produces an ICD-10 code guideline, kind of guide to show the coding types and the variations and what's included. And I'll show you that in just a moment. But through some of the data, there's suffixes, the A, the D, the S that you're probably familiar with when you're submitting the encounters. And so these alpha or these letters that are coming in through your diagnosis codes, they actually mean something when submitting the data. And some of it, when we're using these codes, it may not include the specificity needed in order to hit the HCC code model. So I just wanted to touch on this just a bit on the ICD-10 code structure so that we understand what these diagnoses code mean and how they're being structured in order to ensure that we're picking up codes that risk adjust and those that do not. So when a code ends in an A, the diagnoses that end in A, it means that it's an initial encounter and it describes the entire period in which a patient is receiving active treatment or injury, poisoning, or other consequences or internal causes. So in this particular example, we're looking at T82855A, stenosis of coronary artery. You would suspect that this would probably risk adjust, but in this case, this particular digit of the encounter, this diagnosis does not risk adjust. So when we're looking at the diagnosis code ranges, we want to ensure that all of our severity codes and those codes that we expect to generate RAF or risk scores have the appropriate diagnosis code listed. So as you're going through your ICD-10 book, and there are tools, so there are tools by Optum, there's tools by AAPC, and there's probably tools within your EHR where you're able to run these conditions or diagnoses to ensure that they're risk adjusting and that you're getting credit for the severity level of the diagnoses. There are other diagnoses codes that end in D, and you'll see here that these are subsequent encounters. So it describes an encounter after the active phase of treatment when the patient is receiving routine care for injury during a period of healing or recovering. So there are certain codes here, and you'll see examples of these particular description of codes, and those will also not risk adjust. So it's important to understand when your billers or coders are applying a diagnosis code, that if it's meeting a severity or specificity level, that we're applying the correct code so that it goes into the risk adjustment model. And then the third is sequela. It's the 7th character extension, and it indicates the complication or the condition that arrives as a result of direct injury. So in some cases where we have fractures here, you'll see samples of those codes. So I think the point of this slide is to ensure that when we're applying diagnoses, that the specificity code exists and that we're applying out to the correct digits and that we're noting the appropriate complications when they apply so that we're getting risk adjustment on those particular codes. The slide here is, we're trying to understand proper coding of complications. CMS provides an ICD-10 official guideline and coding reporting guide. And what that guide does, it kind of gives you the explanation and information on how to apply certain codes, understanding rules on how to code so that you're able to maximize and capture particular diagnoses. So one particular important guideline is the definition of the word with in section IA 15 of the guideline. In an index entry, code title, or instruction, we use the term with or in some of our progress notes. So when we're using with or in, there's a presumed relationship between the conditions. So these conditions can be coded as related, even in the absence of the provider documentation, not listing them. So what I want to do is I'm going to just switch over here to this coding guideline. So these are the official ICD-10 coding guidelines and reporting. And so if you don't have a copy, we'll be sure to share this copy, but they're very, there's helpful information in terms of how to document particular categories and conditions by chapter. It also indicates how to use the words with, history of, in, and how to understand the documentation and code guidelines that are defined in the coding manual. So we'll share this document, but it's very useful, very helpful information when you're applying diagnoses and codes in order to make sure that you're assigning the proper linkage between two documents. So if you have one primary diagnosis or severity level, those linkages to specified other conditions or manifestations are important. One, because it's going to provide an additive adjustment on certain diagnoses. So by linking, you can get an increase of RAF if you are documenting all of the pertinent conditions related to those charts. Again, let's talk. So this is still moving forward on the ICD-10 code chart. Diabetes, I noted a few charts here related to diabetes and examples of diabetes because it tends to be our most commonly underreported diagnoses. Not underreported because we are getting the diabetes, but underreported because we're not getting the complications and the manifestations associated with the diabetic codes. So the HCC code, well, here is just explaining the population. So, you know, we get a large amount of members over the age of 65 where we're seeing diabetes in their histories and their charts, and it definitely impacts the reimbursement. So when we're documenting and coding diabetes, we want to be specific. We want to understand all the complications, and we want to see the diagnoses codes related to all the crossovers and complications that are related. So for instance, E11.9 type 2 diabetes without complications, it's assigned to HCC 19 in the model. But E11.36 type 2 diabetes with diabetic cataract is assigned to HCC code 18. HCC code 18 has a higher relative weight than HCC code 19. So supporting the idea, so although you're submitting the diabetic code here under E1136, it's not going to hold as much weight on the HCC code model, whereas you're giving us the code under category HCC code 18. So it's just important to understand that the conditions that are associated with diabetes or all the chronic disease, it's going to fall into one of three of the diabetes HCC code category. So the more documentation you provide, the higher the relative weight will be when capturing and coding the HCC for diabetes. So the status codes that we're listing here, there are several status codes, and we tend to believe that Z codes will not risk adjust on the model. So, you know, many years we think that the Z codes are reporting codes and they're not going to risk adjust. But there are examples of status codes that will crosswalk to an HCC code category. So we're looking at asymptomatic HIV, there's a Z code. We're familiar with the BMI, so we know that BMI greater than 40 will risk adjust. We ask that in addition to your Z code for BMI, that you're also documenting morbid obesity in your chart. So obesity alone will not risk adjust. So it's important that you document morbid obesity when listing BMIs greater than 40. Also, we have long-term insulin use. So when you're diabetics, the Z code, when you're documenting long-term insulin use, there's additive values on risk adjustments there. And of course, we talked about the amputations, artificial openings, kidney status kidney transplant statuses, and if they're dependent on respirators or ventilators, we should also document those Z codes. So these are just examples of Z codes that will risk adjust on the model. So if you don't have those documented part of your chart, let's get those in the medical records. Maybe take a look back on some of your members to resubmit diagnoses for these conditions for calendar years 2019 and 2020. And now that we're in 21, if you're assessing, to include those. So these are more examples of commonly missed chronic diseases or conditions. So just for your reference, if you'd like to go back to your charts, look for amputations, look for rheumatoid RA, morbid obesity, look for any of these conditions that may have not been reported or underreported as not specified in your medical records. We may want to go back and look for the commonly missed diagnoses or HCCs. So here we were talking about diabetes and some of the ICD-10 code structures. So this is an example of what we tend to see in the charts from encounters and some of the progress notes. So here's an example of a diabetic patient without complication. It falls under HCC code 19. They also gave us a code of N39 for urinary tract infection, which does not risk adjust. So here you'll see that we have part of the chart that came in through encounter. But when we review the specific medical record, we found that there was an opportunity for additional risk adjustment reporting. So we captured the diabetes stage 2, but as you can see here, there were manifestations for that particular member listed under as CKD. So we then moved from this particular HCC up above, 19, to being more specific with a chronic disease, CKD chronic disease attached. That raises our HCC to now HCC 18. We also included CKD stage 2. And so as we discussed earlier, CKD stage 3 and above are the only codes that will risk adjust. However, we documented it and it's now showing in the patient record, but it does not risk adjust. We also found that based on that chart, there was malnutrition, which was not reported. So we also coded the malnutrition, which falls under HCC 21. We continue to document the urinary tract infection because it was in the chart, but it doesn't risk adjust. And the old MI I-25.2 was also in the chart in the history section, but it does not risk adjust, but we kept it in the documentation. And then we also found that there was an amputation in the chart that was not recorded. So as you can see, and this is a real sample chart, so you can see through this example that we were able to add additional diagnoses codes by documenting or by looking at the progress note, reviewing all of the conditions, and then coding them out in the encounter record, which would definitely increase and maybe in some cases double your RAF if we're picking up all the diseases and the chronic conditions that were documented. So here is the disease hierarchy for diabetes. So we talked about diabetes HCC code 17 with acute complications, diabetes with chronic complications, HCC code 18, and diabetes with complications, HCC code 19. So below you'll see a sample of the HCC code model. And we won't get credit for 17, 18, and 19 at once. So there's a hierarchy and there are codes that trump others. So if we're showing HCC code 17, it's the highest of the three. So it will trump HCC 18 and HCC code 19. And this is where our specificity comes in. So if we see HCC 18, it will trump HCC code 19. So all of the conditions that we're seeing documented with diabetes without complications, it's not going to pay as high as it would if we were showing the diabetes with the chronic disease or complication. So as you're documenting your diabetes, be mindful of the specificity and the additional conditions associated with diabetes, because the goal is to get into these HCC either 17 or HCC 18, which have the most specificity and will warrant the most RAF or the payment as it relates to those conditions. Disease interactions. So disease interactions are factors that we add to a particular HCC code score. So this is it's an older chart, but the concept is still the same. It's showing that we have a patient with CHF. We also had a patient that had diabetes with chronic complications. So there is an HCC score and payment for HCC 85 at 0.32. There is also payment for diabetes with chronic complications, HCC code 18.31. But when the two are combined and documented together, there's a disease interaction of CHF and diabetes that's scored on that's paid on that particular RAF. So if we only would have documented CHF and not the diabetes, we only get the 0.32. When we documented diabetes along with that CHF, this interaction of these two conditions together gives us an additional 0.154 on our HCC code payment because we documented completely and the model identified those two conditions as being an interaction of CHF and diabetes, so it increases the RAF. So as we're coding and documenting, although these are separate conditions, if they're present in the history, present in the chart, document everything that exists so that we can increase RAF by looking at interactions between two conditions or diagnoses. Here, I won't go through the incomplete chart, but these are common errors that we find through encounters. So, not documenting to the highest degree of specificity and being very vague when documenting cancer status and conditions such as hepatitis, which are not documented as chronic. So these are generally the common errors that we find in encounter data, we find through progress notes. So this presentation, once you have this, it's probably worth going through your billers and coding charts, maybe EHR, reviewing to make sure that you don't have any of these issues. These are definitely issues that would require a reduction in RAF or certain information not being documented in your chart. So most common errors that we see when submitting encounters and progress notes. So here we have more examples of CKD and diabetes. So this chart provides you with the GFR of the patient, the stage, and the ICD-10 that we'll use for staging CKD disease. To the right, this is my right, are the diabetic codes. So you'll see here, these are the diabetes diagnosis codes. Over here in the yellow, we're identifying where to use an additional diagnosis to identify the stage of the chronic kidney disease. So those two together, not only will we get the interaction, but it gives the complete picture of the patient's diabetes as it relates to CKD stages and when you should apply the additional code to identify the stage of the disease of the chronic condition. And of course, this is very helpful. It gives you the GFR and the range or the ICD-10 code that should be applied to identify the stages. Reminder that we want to assign down here at the bottom where you see the Z99.2. So if the patient has dialysis status or if they're non-compliant with renal dialysis, so we can document additional codes that would apply towards your risk score by giving us all of the status codes that would be associated with diabetes and CKD. So more examples on documentation and coding of diabetes. So this is our diabetes chart for type 1 diabetes. So we see our primary diagnosis code for type 1 diabetes with kidney complications. Here, we're looking at E1021, E1022, gives us our type 1 diabetes and if it's specific to neuropathy or kidney disease. Then we're also going to use an additional code to document the stage of the CKD. And so throughout this chart, you'll see the primary diagnosis for diabetes. There's the manifestation that's highlighted related to that condition. In this particular case, for the ophthalmology complications, we can document if the right eye or if it's the left eye or if it's bilateral, we have that specificity in the codes that we're able to document. And then additionally, if it's macular edema with or without a retinopathy, we also have specificity on the ICD-10s that we could use in order to document. So you'll see highlighted here in red are the manifestations associated with diabetes and the secondary codes that we should use to apply or additional codes used to apply the manifestations when documenting diabetes. Same situation here with diabetes type 2. Same example, all of the manifestations that are associated with diabetes, and then all the secondary and additional codes we should use to apply for type 2. So documenting if it's type 1, type 2, the stages, any manifestations associated should be coded and documented in your charts. So here we talked about, potential missed opportunities to increase the RAF scores. So this is an encounter record where we're showing a patient with diabetes type 2 with routine follow-up. The hemoglobin A1C is 8.3, stable on COPD and oxygen dependent. So when we see the chart, we saw the chart come in as COPD. It has a RAF of 3.28. We also saw the diabetes code unspecified with 0.118. So the risk score for this patient on this particular chart is 0.44. When you review the chart based on the scenario, the documentation here, we can see that we added the COPD. There was documentation that the patient was oxygen dependent, so we coded the information there. There's respiratory with hypoxia in the chart, so you can see that was not previously documented above, but with the capture of that additional diagnoses, we pick up an additional RAF. The diabetes above was not specified. We specified the diabetes with hyperglycemia, which increases the RAF, which almost doubles the payment that we received through the model. So just this information that we had here, we were able to document all of these conditions to double the amount of RAF score that we received on a particular patient. So documentation and specificity is key to maximizing your RAF score. And with that, those are let me just, one more reminder here. A reminder that August 1st is the sweep date for 2019 service dates. September would include service dates for 2020 and 2021. So we are looking at documentation through either supplemental encounters coming in through your CSV file posted to SFTP site. You're also able to resubmit your in additional encounters using the clearinghouse through one of the payer IDs that Brand New Day has. We will also accept your paper charts. So if you have paper charts that you'd like to submit secure, our coders will evaluate the charts and complete some coding via paper charts. So those are all methods that you can submit in order to ensure that we're maximizing and capturing your encounters. So Liz, I'll open it up if there's any general questions. We tend to take the specific coding questions offline. Then we will return that back to the group via email so that we are properly giving you the correct codes and documentation. But Liz, if there's any general questions, we'll go ahead and open that up for questions now.
Michelle, we don't have any questions in the chat today.
Okay.
And if all the attendees could please put their email address on the chat so we can go ahead and email you today's presentation along with the CM guidelines that Michelle will be providing. Thank you.
Okay. Okay. So we'll get the information displayed. We'll keep the presentation here so we can capture any new emails where we have not previously had them on file. Documentation will be posted and distributed to everyone. So if there's no questions, we'll stay on just a moment to pick up any questions in the chat. And we thank you for your participation. We will see you again next month. Thank you.